Welcome everyone. My name is Brad Chickwin, and today we're going to learn about capnography made easy. In class today, we're going to cover basic A&P of the upper and lower airways, discuss oxygenation versus ventilation, cover how to do a proper respiratory assessment, compare and contrast end-tidal CO2 versus SpO2, discuss the clinical applications when to use capnography, really deep dive into what a capnogram waveform looks like and how to interpret it. And then we're going to review the documentation expectations in your PCR. So we've all seen this diagram many times, structures of the upper airway. The big thing to remember is it's all the same highway to the same location. End-tidal CO2, we typically utilize that in the nasopharynx. That's where our readings will come from. But sometimes people will use the end-tidal CO2 in the oral pharynx when we use the one that we attach to the ET tube. Components of the lower respiratory tract, remember with end-tidal CO2, and especially when we use CPAP, it's really affecting the offloading of the gases at the cellular level down in the alveoli. So this exercise is better in person, but what I have folks do is take a deep breath, hold it for as long as you can, and then exhale. When I do this exercise in person, I have that individual on nasal end-tidal CO2 and SpO2 to demonstrate the delay that occurs with SpO2 versus the real-time feedback that end-tidal CO2 provides to us. So let's talk about inspiration, the basics of breathing. What happens is the chemoreceptors in the medulla sense an increase in CO2 levels, which causes us to take a ventilation or a breath in. The diaphragm contracts downward while the intercostal muscles spread out. There's a decrease in the pressure inside the chest, therefore allowing the increased volume outside of the chest to have that oxygenation go into the chest itself. The difference of the pressure inside the chest versus the outside is what causes that air to move into the lungs. On the flip side, when we breathe out or when we exhale, the chemoreceptors in the medulla sense a decrease in CO2 levels, which stops us from breathing in. The diaphragm relaxes upward and the intercostal muscles of the chest tighten. There's an increase of the pressure inside the chest, causing a decrease of volume inside the chest. The difference in the pressure from the inside of the chest versus the outside of the chest causes the air to move out of the lungs into the atmosphere. So the best way to break down oxygenation versus ventilation, because folks seem to get this mixed up and use them interchangeably, is oxygenation deals with when we inhale, where ventilation deals with our exhalation. So when you oxygenate the tissues, the air goes into our lungs, where the gas exchange occurs at the capillary level. It's then transported the tissues through the bloodstream, where ventilation is how we get rid of the carbon dioxide through the movement of the air. So we've used that oxygenated blood through the inhalation through our system. The waste product comes back through the blood into the lungs, and then we exhale it out through the alveoli. Our oxygenation goal. So there are different forms of literature out there, but the average oxygenation goal for a person without any comorbidities is 94%. A lot of times you'll see ranges 92 to 94%. This is super important because we don't want to give our patients too much oxygen. So if you have someone who's short of breath and you're giving them a duoneb treatment, for example, and you get their oxygen saturations to 94, 95, 96%, that's perfect. You don't need to get it to 100%. On the flip side, remember, COPDers live in a world where their normal SpO2 is 88 to 90, and very rarely can you get it any higher than that. So if you respond for someone with COPD and they're short of breath and their sats are, say, 84, which is low, it's low for everyone, and you do give them a duoneb or you give them some Dex or you put them on CPAP and you get their O2 saturations to 90, that's perfect. because again, they don't live in the same world we do without COPD in the high 90s. In order for us to treat our patients, we have to assess them first, we diagnose them second, and then we treat them third. Some people have always said EMS does not diagnose in the field. That is absolutely incorrect, because if we didn't diagnose, we would treat our patients exactly the same every single time, and we do not. We diversify our treatments based on our presentations of the patients, and then as they respond to our treatments, we adapt and continue to treat. So please, please, please remember, we have to properly diagnose our patients in order to treat them properly. So in order for us to treat our patients properly, we're going to work on our respiratory assessment. So when it pertains to our respiratory assessment, it's really important to know what the baseline normal rates of respiratory are before we start to treat. The cardinal rule of thumb is the younger the patient is, so as you see with this diagram, from birth to 6 weeks or even 6 months old, their respiratory rate is higher than that of an adult. So it is not appropriate to say that the vital signs are normal on a pediatric patient, let's say who is 6 years old, whose respiratory rate is 10. That is actually low. Or on the other side, you say someone who is an adult, say a 34-year-old, and say their respiratory rate is 60, that also is abnormal. So again, know what your normal rates are. It will help you better treat your patients. Here is the assessment triangle. We typically see this triangle with our pediatric patients, but I like to adapt it and utilize it in all of my trainings because I think it does a good job of giving you a visualization on whatever assessment we're performing. So I've taken the assessment triangle, the appearance, work of breathing, and circulation of a patient, and adapted it to the respiratory setting. So you walk in, here's your doorway assessment, right? So you walk in, you look at their appearance. Do they appear to be breathing or not? That's a big one. What's their skin look like? Is it pink or blue? Are they looking at you? Are they head bobbing? Or are they so focused on their breathing that they don't know you're there? Then you shift to the work of breathing. Are they tripoding? So remember, that's when they're kind of sitting at the end of their chair with their hands on their knees and they're really trying to open up those airways to get some good air in there. Do you notice accessory muscle use? A lot of times our patients aren't wearing a shirt for whatever reason. You should be able to tell right there looking at their rib cage or their belly if they're using any accessory muscle use. The doorway lung sounds. We see these a lot with our asthmatics when you can hear the wheezes when you walk through the door, or remember our pediatric patients at night with stridor. You don't need a stethoscope to listen to lung sounds for those folks. And then are they coughing? Remember, coughing could be a good thing. They could be coughing up the phlegm in their airway if they have CHF. They could be coughing because they've choked on something and they're getting that airway clear. So coughing isn't necessarily a bad thing. It means that there's some sort of air moving, but remember, it also could mean a partial airway obstruction. And then circulation. So even if that patient is tripoding, when you walk in, get down on one knee and introduce yourself, reach out, check their radial pulses real quick. Is it fast or slow? And at that same time, you can kind of determine what their skin moisture is. Is it dry or hot? Again, a lot of stuff we can tell just by walking through the door in that first 10-second assessment. Positioning. Rule number 1. This goes back to EMT Basic School 101. If someone is short of breath and they are laying down, the first thing you need to do is sit them up. Absolutely critical. Sit them up. Obviously, if they have a neck collar on for whatever reason, or they're in full spinal mobilization, you can't sit them up. In that case, you would just prop the head of that device up as high as possible. But again, 99% of our patients who are short of breath, a lot of times we find them laying supine in bed or on the couch, or they're just not sitting straight up. Let gravity help you. Put them on the end of the bed, put their feet on the floor, sit them up nice and straight, and then begin your assessment. It should be the first thing you do. The next thing you should do on all your patients, look at their airway. The whole point of looking into their airway is if down the line you need to intubate them, you've already had a chance to peek in the airway. A pen light or your phone light works really well to kind of get that Mallampati score. which is what I'm trying to list below. So you have a class 1, class 2, class 3, or class 4 airway. Class 1 is the easiest in theory to intubate, where class 4 is the most difficult in theory to intubate. Again, why not look into the airway on every single one of your respiratory patients to get this score? It also gives you a chance to look at their hydration status through their mucous membranes. You can see if their tongue is swollen, if they have any edema inside the airway itself, if they have any teeth or dentures. You might be able to pick that out as well. So you can get a lot of information if you just take a peek in the airway while they're still alert and talking to you. And again, it only takes a second or two. A very, very important question to ask all of your patients who are having respiratory distress. It's probably one of the most important questions you need to ask. Have you ever been intubated before? Sometimes patients will be like, what do you mean? Rephrase it for them and say, have you ever had a tube put down your throat to help you breathe? Approximately 20% of patients who have been intubated in the past will require it again if experiencing a respiratory emergency. This is super important because if you're at the basic or the advanced level and you haven't called a paramedic yet, you should absolutely make sure this question answered yes is a huge reason to call a paramedic and pass that information along to the paramedic. Because as we're treating these patients with CPAP or bronchodilators, we are going to be setting up for intubation because we might have a very small window of opportunity to secure this airway before they decompensate. So again, one of the most important questions to ask during your history gathering assessment. Landmarks of lung sounds. So a lot of us in EMS have kind of gotten used to just listen to the front of the chest. Ideally, listen to the front of the chest and the back of the chest. There's a reason why in the hospital setting, when you watch respiratory therapy or anesthesia do their assessments for lung sounds, they always go to the back. And why is that, do you ask? There's typically less adipose tissue in the back. You're not going through breast tissue in the front or a real muscular guy with muscle pecs in the front, in the back. For the most part, people don't have a whole lot of adipose tissue in that back. So again, you want to compare side to side. So do say from the back, the left upper, compare that to the right upper, and then go to the left lower, compare that to the right lower. So that way you have that comparison. It's not overly effective to go left upper, left lower, right upper, because you're not really comparing a whole lot. So alternate side to side. And don't forget to listen underneath the armpits as well for those parts of the lungs. Lung sounds. So these are super important. Again, it's really hard in the back of a moving ambulance to get really good lung sounds, but that's why it's important to bring in your respiratory equipment into the home when you have shortness of breath calls and get those baseline lung sounds right there in the house. Because depending on how the lung sounds sound, your treatment should be tailored towards those lung sounds. If you have someone who has wheezing, they're probably going to need bronchodilation versus if you have someone who has rales and sometimes rhonchi, you probably need to go to CPAP. And stridor typically is of a foreign airway body obstruction. So again, take lung sounds on every single patient. So that way there, if you listen to 8 patients with nice clear lung sounds, on that 9th patient when it's abnormal, you pick it up instantly. So part of your ongoing assessment is the airway self-maintained? Looking at that picture with the lady, that's the tripoding position who's trying to gasp for air. At this moment in time, she is able to maintain her airway, but it might not necessarily be the case for the entire call. When you take a peek in the airway, do you notice any secretions or is there any swelling in that oral pharynx, so that whole part of the mouth and the back of the mouth? What were your airway or doorway sounds when you walked into the room? Super important to ask if they have difficulty swallowing, especially in our pediatric population, right? Or our stroke patients. Someone's having a stroke and you're doing a stroke assessment. If you ask them to swallow and they cannot, in the back of your mind, you should be thinking that their airway is involved and you might lose that airway. Same thing with the pediatric patient. If they can't swallow, you can lean more towards something like epiglottitis. So if a patient can swallow or not is super important. The adequate rate and depth, that's pretty self-explanatory. The pattern of inhalation versus exhalation, is it regular, meaning you typically, let's just say for comparison purposes, it takes you 1 second to inhale. It should take you a second or 2 to exhale. That's just normal. With our COPD patients, it might take a half a second to inhale and then 4 seconds to exhale, for example. That tells us something about their comorbidities, so it's super important to ask that. Accessory muscle use. Yes, you need to visualize the chest for this. So on your respiratory patients, when you're doing lung sounds, maybe you should be taking it skin to skin with your stethoscope and not over clothing, because at the same time, when you're doing it skin to skin, you can look at their accessory muscle use. Pursed lip breathing. We see this typically in two types of populations, in our COPD patients in the elderly, and then with our respiratory distress patients in the pediatric population. Cyanosis of the lips or extremities. Remember, as they become cyanotic, typically the blood starts to be hyper-focused on the internal components of the body. So the first places to lose that circulation is your lips, the tip of your nose in respiratory patients, your fingertips, or even your toes. Patient positioning, are they tripoding? If they are tripoding when you arrive on scene, that should be your first sign that you should be intervening with some sort of treatment immediately. A lot of these patients do well with bronchodilation. Maybe they're having an asthmatic attack. Maybe you need to do a duoneb. Maybe they're allergic reaction, you need to give them epi. Maybe they have flash pulmonary edema with CHFs, you need to do CPAP. If they're in the tripoding position, you need to do something for them before you move them. It is not appropriate to throw in a nasal cannula and try to get them comfortable in the stair chair. Okay, you need to intervene if people are tripoding. They are not circulating the right amount of oxygen. Dyspnea, remember that is speaking between words, between sentences. So you walk into someone who's short of breath and they're able to say, my name is Kelly, 1 and 2 word dyspnea, versus someone who's short of breath and they're able to tell you all the headlines on the news and the weather and how many grandkids they have before taking a breath. Typically not as severe. And then their baseline SpO2, and if they're on HOMO2, this is important with our COPD patients, right? We need to know if they're on oxygen all the time, only when they sleep, only when they ambulate, and then how much oxygen they're on. Because ideally, right, so if you have a COPDer who is short of breath and you put them on CPAP, which is more than appropriate, and they do really well with that, and then by the time you get in the hospital, they're talking to you in full sentences, depending on your patient, it is appropriate to start weaning that oxygen back down, if you think it's appropriate, to get them back to their baseline, which might be 4 liters via nasal cannula. Because remember, COPDers are not designed to stay on high flow oxygen for hour after hour, day after day. So let's talk about respiratory effectiveness. So in our measurement systems, after our assessment, because our assessment absolutely is our number one skill that we bring to the table. Doesn't matter what equipment we bring in to treat these patients, our assessment is key. You need to have a good assessment so you know how to treat these patients. When it comes to our measurement systems, typically we have, outside of the physical assessment we provide, there are 2 different systems we measure. Oxygenation using the SpO2 and ventilation using capnography. I will always advocate that if you have a respiratory patient to utilize both. Because again, they're all pieces of the puzzle, but the more pieces of the puzzle that you have a clearer picture of what's going on. So the comparison between the two. Capnography, so your end-tidal CO2, is the immediate picture of the condition versus the pulse ox, which is a delayed picture. You can do it to yourself someday if you're bored, or you can do it with your patients. If you have a patient on end-tidal CO2 that starts to desat, you will see that change in the number or the waveform immediately. And sometimes there are several minutes of a delay before you start to see a drop in SpO2. Again, end-tidal CO2 is real time, pulse ox is delayed. So kind of a side-by-side comparison. Again, we just covered the SpO2 delayed readings versus the end-tidal CO2 real-time readings. SpO2 measures the hemoglobin in the blood. So that's the transporting of the good oxygen on the red blood cells throughout the body. And then the end-tidal CO2 does cellular metabolism. So after we utilize the oxygen, it's the waste product returning back to the lungs to be expelled. SpO2 deals with arterial oxygenation versus end-tidal CO2 deals with the alveoli hypo and hyperventilation. So again, the cellular level. SpO2 Does a really good job of measuring extremity circulation. We see this when we have patients with cold hands or elderly patients with comorbidities that have circulation problems where we don't seem to get really good readings on SpO2 because it's measuring that extremity circulation, the furthest point more or less from the heart. And then the end-tidal CO2, because it deals with the waste removal, it really focuses on the airway patency. So again, the gold standard in respiratory measurements, end-tidal CO2. If you have an SpO2 reading and you document in your narrative, you need to make sure it's documented with a percentage sign at the end versus an end-tidal CO2 reading is documented with a millimeters of mercury like we do blood pressures, same exact ending. So for example, if you say you have a COPDer whose baseline SpO2 is 80 to 82 when they're in respiratory distress, which is low, right? But their normal is 88 to 90 or 89%. Make sure it ends in percent, not millimeters of mercury. On the other end, you put end-tidal CO2 on a patient and it comes up as 26. It is not 26%, it's 26 millimeters of mercury. A number of years ago, when we started utilizing end-tidal CO2 in cardiac arrest, we realized that this is a reliable measurement of how effective our CPR compressions are in the circulation of oxygenation throughout the body during a cardiac arrest. And our SpO2 is not a reliable measurement in our out-of-hospital cardiac arrest. So our O2 delivery devices. So this is kind of a breakdown. I stole this from an EMT basic book. It gives you the delivery devices and the percent of oxygenation that typically flows through them. So the one I started was your nasal end-tidal CO2. I started this for two reasons. One, remember this is a passive oxygenation device, meaning that it also utilizes the ambient air around the device to be delivered to the patient. Number two, it is not appropriate to do high flow oxygenation in pre-intubation with a nasal end-tidal CO2. It's not designed for that. Nasal cannulas are probably the best device to use for the pre-oxygenation phase, but again, they do make a high flow nasal cannula for this purpose that we don't carry on the ambulance. So the next best thing we have to offer during pre-oxygenation for intubation is a nasal cannula turned up as high as you can do it. CPAP devices and BVMs and your non-rebreathers on the flip side, remember, it can deliver more than the 100% oxygenation, which for some patients that we'll go into later on this lecture is not necessarily a good thing. And the CPAP device is the only one that has controllable PEEP. So here's a very good diagram I found about our nasal capnography devices. Like I mentioned before, it's a passive oxygenation device, meaning it's not 100% oxygen coming through that nasal cannula that we put on the tank. It mixes with ambient air. So it's kind of a closed system where one prong, the oxygenation goes in the nose, and then the other prong is measuring the oxygenation coming out of the nose. So it's not even a full oxygenation device. So again, it's not appropriate for those patients that we're really trying to hyperoxygenate for any particular reason. It's more of a measurement tool. I threw this slide in to give you guys an awareness that there's, like everything else, there is a measurement or a way to figure out how much oxygen's in our tanks and how much we use on certain types of devices. What I tried to portray here for you guys and girls is that if you have a portable oxygen tank, so look at the very bottom, that's completely full with 2000 psi, and you run a CPAP with a neb, so you're running that CPAP right around 15 liters, you're probably going to get somewhere in the area of about 20 minutes on that O2 tank. That's why it's super important for us to make sure we check our trucks and make sure that we have 2,000-ish of PSI in our oxygen tanks on the stretcher and our first in bag. Because if you have to be on scene for a while or go out in the wilderness and you need to utilize CPAP on a patient, you only have about 20 minutes on those. So if you already walk in with an O2 tank that's at 600, you have a fraction of that. The equation above that is when you use a CPAP with the neb on the house O2. So again, the house O2 tank at 2000 psi is a much larger tank, so you have more time. So you have about 220 minutes on a full ambulance O2 tank to run a CPAP, just for comparison purposes. But again, there's an equation for everything.
To connect your patient to end tidal CO2, you will take your connector, you will lift the flap, screw the connection in, and it'll automatically start reading on the left side of your screen. If you notice your machine is not showing waveforms, you can change that by moving using the selector wheel. Move down to an open spot. You can put on your SpO2, and if you'd like your end tidal, choose CO2, and it'll give you your waveform.
So now that we've covered respiratory assessment, respiratory anatomy, and SpO2 versus capnography, I really want to deep dive into capnography itself. So capnography, as we know, is a non-invasive method for monitoring the level of end-tidal CO2 in an exhaled breath to assess a patient's ventilatory status. A true capnogram, so that waveform that we see on the monitor, has a value as well as a waveform. We use it to help diagnose particular medical conditions, make treatment decisions, and assess how well our cardiac arrest efforts are. Again, I can't express this enough. Capnography is real-time feedback. It is not delayed like SpO2. So there's a range for end-tidal CO2. So most lab values, the low number means it's acidotic, and the high number means it's alkalotic. If you remember that whole pH scale, normal pH is anything from 7.35 to 7.45. So we try to live right in that 7.4 range. So if you think of that scale, end-tidal CO2 is one of the only lab values that are flipped, meaning the higher the end-tidal number means that they're actually acidotic, and the lower the end-tidal CO2 number means that they're alkalotic. It's super important to remember that. Remember, end-tidal CO2, those lab values are flipped than, say, a normal pH, where 7.35 is acidotic. Anything less than 7.35 is acidotic, and anything greater than 7.45 is alkalotic. End-tidal CO2 is swapped. Again, people get this confused all the time. The higher the end-tidal CO2 number means that they're acidotic because they're holding on to the CO2, where the lower the end-tidal CO2 number, the more alkalotic they are because there is less CO2 in the blood. So clinical uses. So we can use it for a variety of reasons, and a lot of people just stick to using end-tidal CO2 on cardiac arrests, or they only use it for when they intubate. But just know we can use it for other clinical uses. So first and foremost, we can monitor ventilations. It's also the gold standard for confirmation of intubation. So when we intubate someone, we put this on, so that way there it gives us a continuous reading of our airway patency. We use it during cardiac arrests, during CPR, so we can use this on our BVM, we can use it on the King airway, and we can use it on the ET tube. It's most accurate on the ET tube because that's a closed system, right? It's a straight tube into the lungs. There's a cuff tube at the end, so there shouldn't be any air leak. So that is where it's most accurate. Where with the King airway and BVM, it's not as accurate, but it's again more accurate than SpO2. When we have sedated patients, we use this. You can also use it, which a lot of people don't realize, on our medical patients. So our asthma patients, COPD, CHF, super important to use it on our stroke and seizure patients and overdoses. And a lot of people ask why. Why would you use it on a stroke patient? Again, real-time feedback. If that stroke starts to evolve, it involves the brain that deals with the breathing aspect of things. So if the end-tidal CO2 starts to change, and typically it will increase on your stroke patients, it means it's starting to retain and something has changed. Seizures are the same thing. If you have someone who has a seizure disorder who had a seizure out front of you, and you may or may not have treated with benzos, and you get them in the back of the truck, and you put them on the nasal end-tidal CO2, if they start to have that seizure again, you will see real-time feedback with the change in the waveform of your end-tidal. Same thing with our overdose patients. You show up on an overdose, PD is given Narcan a couple times without relief. You start to ventilate your patient, which you should do on all of your overdose patients. Put them on nasal end tidal or put the end tidal on the BVM. Typically, those patients' end tidals are really high. So you might have an end tidal on an overdose patient of somewhere in the 80s, 90s, or even three figures of 100. As you're ventilating them and they have a pulse, so you give Narcan and you continue to ventilate, you will start to see that end tidal CO2 drop, and you'll see it drop some more. And when it starts to get in that 50 range or 40 range and it starts to normalize, then the patient's eyes will open and you'll start to notice them start breathing again. Again, super useful tool. Management of head injury patients. We don't want to hyperoxygenate these patients, and we don't want to not oxygenate them enough. So this is one of those patients that if you have end tidal on them and you decide that they need oxygen, you keep their ranges at a lower rate, and we'll discuss that later. And then perfusion warning in our septic patients. We'll go into that as well. So it's with our septic patients that are altered that will tolerate it. If you put them on the end tidal, then it will help you with your treatment. Remember, when you use end tidal CO2 on patients, it doesn't mean you have to put oxygen through the device for it to work. So now it's time to discuss the clinical correlation between a low end tidal CO2 and a high end tidal CO2. And a lot of times you see these numbers based on if they're either hyperventilating or they're hypoventilating. So you will see a low end tidal CO2 on a patient who's hyperventilating, who has anxiety, a head injury, DKA, a PE, bronchospasm, and cardiac arrest. Remember, our goal during cardiac arrest is to keep our end tidals in the teens, so anything like 10 to 18 is good. We have better outcomes when the end tidals stay like that until we get ROSC. Cold weather and acute MIs versus patients that are hypoventilating. They typically are retaining their end tidal CO2, so their end tidal CO2 is going to be high. Ultimental status, your overdoses, again, head injury, depending on the type of head injury, it could go either way. Fever, sepsis, severe difficulty breathing, intoxication, sedation, stroke, and pain. So remember how to correct that. If you have somebody who is hyperventilating, has a low end tidal CO2, you need them to slow their ventilation rate. On the flip side, if you have someone who has a high end tidal CO2, you need to increase the ventilation rate to drop that range back into normal. So high end tidal CO2, you increase your ventilation. Low end tidal CO2, you decrease your ventilation. So this is the point during the presentation where I get the opportunity to discuss the use of end tidal CO2 with our CPAP systems. So with our end tidal CO2 systems that we carry, so our CPAPs, let's use them with our CPAPs. They're interchangeable, meaning you can put a nasal end tidal CO2, which is shown in this picture, prior to applying the CPAP device. And because the CPAP device's mask is pliable, it will still make a good seal. If for some reason, so you're an EMT basic and you forget to put the end tidal on, no worries. When the paramedic shows up, because you should have requested a paramedic because you're using CPAP, when the paramedic shows up, he or she should just take the end tidal and apply it on the outside of the mask into the tubing system like we do with intubation. So use the ET tube end tidal CO2. Once you get the CPAP mask on, it is not appropriate to take it off to put the nasal on. So the goal is to put the nasal on before you put the mask on. But remember, if for some reason, because of what was going on scene, you forget to put the nasal end tidal CO2 on, no worries. We'll figure a way to put it on the outside through the tubing system. But again, you can use nasal end tidal CO2 with your CPAP mask. So the pathophys of perfusion. So we're going to briefly go over the Fick principle and VQ mismatch. Simply put though, air's got to go in and out, the blood's got to go round and round, and any variation to either one of those is not a good thing. So VQ mismatch. So ironically, this VQ mismatch came about when they were trying to figure out PEs. But what it is, it's a nuclear medicine study used to evaluate the circulation of air and blood within a patient's lung in order to determine the ventilation to perfusion ratio. So the ventilation part of the test looked at the ability of the air to reach all of the parts of the lungs. The perfusion is how well the blood was circulated within the lungs. And then the test is, again, most often used to determine the presence of a PE. That's why there is a difference between respiration and ventilation. Remember, respiration is just the act of the air coming in, typically with a set rate or whatever your body's rate is. Where ventilation is how well it's crossing that blood barrier down in the lungs and getting into the alveoli and actually being utilized. So there is a difference between a patient's respiratory rate and if a patient's being ventilated. The Fick principle. So I kind of put this to a school bus analogy. So in order to have adequate perfusion to occur, we must have the following. You need to have the correct number of red blood cells. So that's your school bus. You need to have adequate oxygen coming in. So those are your students getting on the school bus. And then there needs to be a place for those red blood cells to offload and take on oxygen. So these are your bus stops. And then for any of this to be successful, you need to make sure that you have adequate blood pressure to circulate all this, which is the gasoline. So any alteration in any one of these is when the body starts to compensate and or we need to intervene. So when it comes to capnography, we really need to know what we're looking at, right? Because it doesn't do any good to hook them up to end-tidal CO2, get this random number that you know the normal range is 45 to 35 or 35 to 45, however you look at it. So if you have an end-tidal CO2 of 57, what does that mean? We need to make sure we change our monitor so we can see the waveform, and again, it helps paint a better picture of what's going on. So like with EKG rhythms, we need to make sure that when we interpret a waveform that we use the same series of steps of the way that we look at them. That way we don't miss anything. So I like to use the ABC acronym for this. So when it comes to a capnogram, which we'll discuss in the next slide, we need to look for the signs of obstructed airway. Then we need to look at what the readings are, and then we need to look at the trending. So a capnogram, unlike, say, the SpO2 or even an EKG, the capnogram wave begins right before exhalation, at the end of inhalation. So it's opposite of what you think. So what this is measuring is the breath coming out. So if you look at this picture, phase 1 is the baseline. That is at the end of the inspiration. As soon as you start to exhale, you have the rise, then it goes to the plateau, then the end-tidal CO2 captures a reading, and then at the end of your exhalation, right before you take your inhalation, goes back to phase 1. So it's kind of opposite than what you think with, say, again, an EKG complex, what actually starts with electroactivity. It's completely different. So a normal capnogram, it's easy to break it down into kind of an A, B, C, D, E picture. So the first part is that A to B, so that line that starts right before the complex. So this is the respiratory baseline or the dead space of that exhalation. So again, it's the end of the inspiration. B is when you start to exhale. So it starts that climb up to C. They call that the expiratory upstroke. And then as we exhale, that's that time frame. So say it's 1, 2, or 3 seconds, right? So you have that exhale. That is the C to D. And when it hits D, that's when it captures the end-tidal CO2 reading. And then you have that inspiratory downstroke when you start to take that deep breath in. And then E is kind of that dead space at the end, and then as it goes back into the inspiration. So again, it is an opposite mindset of what you think the end-tidal CO2 is. It's not like a complex. I can't say that enough with the EKG. It's actually measuring your exhalation. So let's look at the approach of this piece of the puzzle on how we look at a capnogram. So here's that systematic approach. Is your CO2 present? What is that expiratory upstroke? The expiratory plateau, the inspiratory downstroke, and then again we're going to read the end-tidal CO2. So part of that systematic approach is we need to make sure that we properly attach the end-tidal CO2 to the monitor. So remember with the LifePak 15s, it's above the blood pressure cuff in the SpO2 plugins where they go into the monitor. It's really important that when you put the end title in, you insert it easily into the hole, and then you turn it about a half a turn, and that's all you need to do. You don't need to keep turning it like a screw into a board to get it nice and tight. It doesn't need to be that tight. It just needs to be in there in place, because if we do it too tight, we're either going to snap that reading piece off inside, or we're going to strip the threads. So just put it in, turn it about a half a turn. That's all you need to do. So that's step number one. Once we get it turned in, the monitor should go beep, 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 and then we should start to see a number and a waveform, which is seen in the picture on the right. If you look at the low left-hand corner of the picture on the right, it shows the CO2 reading pops up. It gives you 36 millimeters of mercury, so that's how you know it's end tidal and not SpO2. And then it gives you a respiratory rate. Sometimes it's accurate, sometimes it's not, but for the most part it's accurate. And then you need to make sure that your monitor is adjusted through the leads to have that CO2 complex at the bottom. Our monitors, I believe, default to that. So you know it's working when you have a number, you have respiratory rate, and then you have a complex to look at. So is there a waveform? So once you get a waveform, the first thing you look for, again, at the beginning of the exhalation, is it expiratory upstroke? Is it steep, sloping, or prolonged? So if you look at the one on the left, that is a pretty a sloping one, right? So that is very different. It looks more like a shark fin, which you will learn is bad. So that is much more sloping versus the picture on the right is much more steep or box-like, which is more normal. Then there's the expiratory plateau. So this is that piece that goes at the very top of the box, the upper left, and it's kind of that slow incline. So this is kind of the period of time while you're exhaling. Is it flat, prolonged, notched, or sloping? If you look on the picture on the left, there's a little bit of a notch in it versus the one on the right. The picture is more naturally sloping. So again, I try to keep the picture on the right view because that's a normal complex, and those stuff on the left are typically abnormal for comparison purposes. So it looks at the downstroke. So again, we've captured that end tidal CO2 number, and then we start the downstroke of that complex. Is it steep, sloping, or prolonged? So if you look at one on the left, it's pretty funky. It's all over the place. So there's something going on with that, obviously, because it looks like a shark fin. Versus the one on the right, it dips in and then gradually goes into the inspiration. So that's more normal on the right. And now the last piece you should be looking at is the range. Again, 45 to 35 is what I teach, because if it's higher than 45, they are acidotic. If they're lower than 35, they are alkalotic. Remember how to correct it. If you have a high end tidal, you need to increase your ventilation rate to bring that back down into that normal range. Versus if you have a low end tidal, you need to slow your ventilations down to bring it back up to normal. So we can kind of go into the types of patients to use end tidal CO2 on. So the cardinal rule of thumb is capnography monitors patient ventilation, providing a breath-by-breath trend of respirations and an early warning system for impending respiratory crisis. So basically, if you have any patient who's breathing too slow or any patient that's breathing too fast, is a good reason to use end tidal. So looking at these waveforms, these are printouts from the monitor. So we know that our normal end tidal CO2 range is 35 to 45, or 45 to 35, whatever you look at it. When they are hyperventilating, you see an increased rate and you have more waveforms. Just like when you have a pulse with EKG complexes, the more elevated the pulse is, the more complex it is. Same thing with end tidal. Versus hypoventilation, where if they're only breathing 6 times a minute, you'll see very few complexes, but it will correlate the number of complexes with how fast or slow the breathing is. Confirming, maintaining, and insisting intubation. This is our gold standard. So after you intubate somebody, you need to make sure you have continuous end-tidal CO2 monitoring to confirm good tube placement. Not only will you get a number that's accurate, but you will also get confirmation with a range that the tube is in place. Again, we're still going to check lung sounds. We're still going to confirm that goes through the cords. We're still going to use DVL to do all of that. But maintenance-wise, end-tidal CO2 is your real-time feedback of whether or not the tube is in place. What is going on here? So you know it's hooked up to the monitor, the end-tidal is, because you're getting a reading, but it's 0. The number one reason why you have an end-tidal CO2 reading of 0 is that the ET tube is in the esophagus. Again, real-time feedback. If you're ventilating someone, like in this picture here, you're ventilating them and you see the box, and then you're ventilating them again and you see the box, and then you ventilate and you don't see a box, and then you ventilate and you don't see a box. You need to look at that and go, what has changed? A vast majority of time, you have the ET tube is either in the esophagus at this point or has become dislodged. Reassess your lung sounds, confirm your placement. You should get an end-tidal CO2 reading and you keep going. Again, this is real-time feedback, which is important because if you had been basing your treatment off the SpO2, you might do 5, 6, 10, 20 ventilations of air into the belly with a dislodged ET tube before you saw a reading change in the SpO2. So again, end-tidal CO2 real-time. This is when we use end-tidal CO2 during our cardiac arrests. So it'll be the first sign of ROSC with our patients in cardiac arrest. So what does that mean? So we're doing CPR on a patient. I'm drawing up medications. I have Caitlin, for example, doing the airway for me after I've intubated, and she's ventilating the patient perfectly every 5 to 6 seconds. Her end-tidal is 14, 15, 16, 17, 18. Then I go to give some epi and I look, and the end-tidal CO2 is 60. So something has changed. You need to complete your round of CPR before you reassess. Think of it as priming a motor of a boat in the springtime when you take it out of storage. It's going to spit and sputter. It's going to smoke before it actually purrs nicely and you're ready to go in the lake or the ocean. Same thing with ROSC. If you get ROSC and you notice a change in your end-tidal CO2, do not abruptly stop your CPR compressions to see if there's a pulse. Finish your 2 minutes of CPR, and then at that point, check a pulse. You're just priming the pump, and it doesn't hurt anything. But again, you will see the change in end-tidal CO2 before you see anything else, typically in a cardiac arrest with ROSC. So as demonstrated in the previous slide, how end-tidal CO2 does a great job determining that we have ROSC. It also does a really good job of letting us know that we've lost ROSC. Because remember, when it comes to the end-tidal CO2, it's that real-time feedback. So if you have someone who has ROSC who went from 10 to 60 and you're ventilating the patient and now the patient's at say 45, so now you've secured them on the reeds. You need to get them in the back of the truck, and now your end-tidal CO2 is 6. Something has changed. I would check a pulse, see if your airway is still patent. There's a good chance you won't have a pulse anymore, and then you immediately start CPR. But again, if you were using SpO2, there would be a significant delay. So end-tidal CO2 not only can determine ROSC for you, be the first sign that you have ROSC, it also will be the first sign that you've lost your pulse. So as I briefly discussed with that list of reasons to use end-tidal CO2, I mentioned shock or your septic patient. So if you have a patient who you think is in septic shock, here are UTI patients or altered mental status patients in a nursing home. Over a period of time, this will do really well also in your transfers, that you'll start to see a decrease in your end-tidal CO2 in your waveform when you start to see that sudden drop in cardiac output. We use this in our trauma patients, cardiac and shock patients, but again, you'll start to see that trending of that end-tidal CO2 waveform kind of getting smaller. Like, what is going on? You're losing that cardiac output. So if you look at a capnogram, when you utilize end-tidal CO2 in a CHF patient, it looks different from the normal capnogram that I showed you in previous slides 4 or 5 or 6 times. So typically there's an up, the form goes up, but it's kind of at a gradual incline, and then across the top it plateaus, but it goes up just a little, and then you capture the end-tidal CO2, and then it drops again. With the CHF patient, it looks like a rectangle. So you have that abrupt, straight up form, and then it goes more or less flat across the top, and then it drops back down again. So you notice this looks very different from the regular one. This patient is in CHF, because what's going on in CHF, right? They're having issue getting rid of fluid, or doing that VQ mismatch. So look at this capnogram. It actually looks flipped from the normal, right? Because typically with a normal one, you take the exhalation, it goes up, and then it kind of gradually slopes up, and then it comes down. With emphysema, it flips. So remember we discussed with our emphysema COPD patients, right? You have that gradual effort to get rid of the CO2. In emphysema, it's that air trapping. So it causes that prolonged expiration. You also could see this in your pneumo patients. This is also called a B wave. So if you look at this diagram, it kind of looks like a shark tail with a bite taken out of it. These are for your asthma and COPD patients. What is going on in asthma and sometimes with COPD? You have that bronchospasm. So the patient is struggling to exhale. So they're able to take that breath in, but they have trouble getting rid of that air. So there's that sharp incline versus the gradual slope. So this is a printout, 3 different printouts in a code summary with the use of end-tidal CO2. So this provided a really good job. So first I will say this patient is not intubated, but this provided a really good job of capturing an end-tidal CO2 reading before a treatment, the start of the treatment, and then after 2 nebs. So remember the normal range of CO2 is 35 to 45. The first strip across the top has a very low CO2, means that they were not retaining CO2, they were expelling it, so they were most likely hyperventilating for whatever reason. And then he started a treatment. He started to open up those airways. You started to see the increase in the CO2, so it's going more into the normal range. And the complexes started to form as that swelling in the airway started to decrease. And then after 2 neb treatments, which is the bottom strip, it has more or less a normal complex. Picture perfect example of how effective treatments were for this patient utilizing end-tidal CO2. With an obstructive airway, remember I kept on saying, oh, it looks like a shark fin, that's a bad sign. This is if you have that, so you have, let's say you have a patient with stridor. You'll probably see this. You have a patient who's choking, God forbid. You would see something like this. It's that partial airway obstruction. So this is that classic VQ mismatch, because that patient is trying to gasp for air to get some air in. That's why you have that shark fin appearance where it doesn't ever actually plateau. It goes kind of from the exhale to when they try to take another breath again. When they exhale to when they try to take another breath again. They're not getting that conversion at the cellular level. Shark fin is bad. Ventilating head injury patients. So I would always advocate that if you have someone who even think has a head injury, that if they will tolerate it, you put the end-tidal CO2 on them. Because the goal is to not hyper or hypoventilate these patients. If you hyperventilate a patient, it decreases the ICP, but it also decreases the blood flow. So that's bad. If you hypoventilate, then you're going to have all the dilation going on inside the brain, and then there's going to be a flooding of oxygen into the brain. That is also bad. So what we try to do is if you have your head injury patients on end-tidal, which you should, You try to keep their end tidal within normal ranges, but on the low end of normal ranges. So keep it right around 35-ish, 32, 33. Again, don't base your treatment off of your SpO2. The better question to ask yourself is, what patients do you not utilize end tidal CO2? I hope I've painted a picture for you today with this training of all the different applications when we should use end tidal CO2, and I hope you do. It's a valuable piece of the puzzle. So to recap this presentation, if there's a decrease in end tidal CO2, it means that they have blown off all of their CO2. You need to decrease the ventilation rate. Whether you coach them to slow their breathing down or you take over their airway with a BVM, you need to slow the rate. On the flip side, if they have an increase in tidal CO2, so they're holding on to the CO2, they're not off-gassing it. Here are your overdose patients, for example, or asthmatics. You need to increase the ventilation rate. So whether you have them breathe a little bit faster or you increase your ventilation, you need to increase that rate in order to bring those numbers back to within normal range. With all of our respiratory distress patients, don't forget to go back to the basics. The quickest and easiest and least invasive way to possibly increase someone's SpO2 or improve their end tidal CO2 are done with two simple things. Have them take a deep breath or a couple deep breaths and then have them cough. Deep breath and cough. It's something you can do right on the bedside. It takes a matter of 3 seconds for them to do it. You should do it on all of your respiratory patients, because just by taking a couple deep breaths and introducing some more oxygen or coughing to loosen up some mucus in the airway, sometimes you'll actually see a significant jump in your SpO2s and end tidals in your patients. This also is really true and good to do after you give your bronchodilators. So you give them a neb treatment, have them deep breathe and cough. Give them another neb treatment, have them deep breathe and cough. You can do the same thing when they're wearing the CPAP mask. Take some nice deep breaths for me. It works. It's simple, and sometimes we forget about it. So, documentation for me first. There are 4 things we want to make sure we include. So we have our respiratory distress patient. We put them on SpO2 and end tidal CO2. What is the reading before your treatment, as well as the waveform? The second thing you do is, what are the end tidal CO2 readings during the treatments? What are your end tidal CO2s after your treatments? And then a really good description of that waveform. So it's good to have the numbers before you do a treatment, during the treatment, after the treatment, but don't forget to describe the waveform. Even if you did the waveform at the very beginning and the waveform at the end, it's super important. Again, the best skill we bring to our patients, no matter what the chief complaint is, are our assessments. Our assessments are key. We do really good histories, we do really good hands-on physical assessments. It will tell us a lot about the patient. The use of end tidal CO2 is just a small piece of that puzzle. It's effective, it's important, but again, it's just a small piece of the puzzle. Don't forget to use your clinical skills first. Excellent. Thank you everyone for listening. Don't forget to take the quiz and then sign the roster when you're done.